So, welcome to an interactive session focusing on tiny lesions we see more and more often in the CAT scan we are offering our patients. So, what the hell we should do with those little lesions? And it's a great pleasure to share cases and ideas with you together with good friends. I have support from Italy, Giuliana from Milano. I have support from France, Sami extra came for that event, and my name is Felix Herth. I'm from Germany, Heidelberg, and we will show you the problem, we will show you possible solutions, and we will show you also that you have opportunities from Olympus that you can do everything in one shot. As mentioned, the session will be interactive, so we have a couple of questions for you. To answer the question, you have to scan the barcode if you haven't done that in one of the last sessions, and then you have to vote, and just for training reasons. I want to know you belonging to company A, to company B, C, or D, so all the competitors who are in the room, or you are a physician. And if you are a physician, are you a respiratory physician, or a radiologist, surgeon, oncologist, or what the hell ever? So therefore, okay, no enemies in the room, yeah? So we have it under control, yeah? So that might be influencing the voting results, yeah, maybe. So we have 100% for our technologies in every questions we have. Just moving forward, I will give you the intro why I believe that we running in that nodal area. We have lung cancer screening. These are the randomized controlled trial, and every trial shows the same. It works. We find lesions, and when we diagnose that lesions, we have a couple of cancer patients in that subset of lesions, and in those patients we have better survival because we can resect them. So the US approved it, Croatia approved it, the rest of Europe is debating, but I think we will have lung cancer screening programs available within the next coming years. To be honest, I don't need a lung cancer screening to increase my business on tiny lesions because CAT scan is more and more used at the moment. So we have the screening programs, but I got a lot of referrals from the cardiologist. When you have chest pain, you go to the cardiologist sends you to the cardiac CT scan, you have findings on the vessels or not, but you have maybe a nodule. So 10% of our nodules, our incidental nodules, are referred from the cardiologist. And that is, the use is increasing. So we ourselves doing more CAT scan. Every COD patient gets a CAT scan nowadays. Question endoscopic lung volume reduction, acute exacerbation, question is pulmonary embolism. So you do more CAT scans on your CVD patients which are on risk for nodule. And even oncology gets better and better and better. So we have now the immunotherapy in lung cancer, so we have long-term survivors on lung cancer, and we're seeing a second round of cancer. And even in other cancer disease, in other organs, the treatment options get better and better and better, so the number of metastatic nodules is increasing. So we're seeing the nodules, and we have to find solutions for that. When you go for guidelines, I just have taken the NCCN guideline, there's the BTS guideline, there are Fleischner Society, more or less paste and copying from each other. It's always the same people who are doing the guidelines for the various societies. And the guideline is not really supportive. Okay, you have to look to the size, and the next version of guidelines will also have the volumetry within you. You have to measure the volume. But then when you have high suspicion, the guideline just let it up to you what you do. Biopsy, whatever that means. Yeah? So there is no clear recommendation from the guidelines what you should do when you have a nodule. So then it's up to us. And that also is a little bit influenced where you are. In Germany, for example, it's more regulated by the respiratory physician, so I can make the decision where I send the patient to, surgery, radiology, or bronchoscopy. But when maybe the GPs are more the group who is doing the regulation of that, they may be have an influence who will do the biopsy. So we need biopsies how to handle the small nodules. There is one guideline focusing on the incidental nodules, so those you find not for screening reason, and it looks a little bit more complex, but at the end it's the same. They're measuring the size, and depending to the size, biopsy, watch and wait, or directly resection. And again, that guideline leaves you alone regarding how to diagnose it in case there is a need for a diagnostic, for biopsy workup. So what the hell we doing as physicians? So we're looking a little to the patient, we're asking the smoking status, we're asking, is there a history of cancer in your family? And all those factors influencing us next to the measurement of the lesion, if we're recommending a biopsy or not. And also, what is never written in guideline, but in our daily doing, it's very important. We have to talk to the patient. What the hell you want? Can you sleep knowing that you have an 8 millimeter nodule in your right upper lobe and we're recommending a CAT scan in 3 months? Or can you are so crazy regarding that nodule, then maybe it's influencing us to go for a biopsy, but the patient wish is never mentioned in any of the guidelines. It's pure focused on our interest. So what we have to do regarding that, first of all, regarding the incidental nodule, we have to create awareness. There have been huge retrospective analysis where they went to 10,000 CAT scans made by the cardiac indication, and they have had found in 10% of that CAT scans there have been a nodule. So this is what the expectancy is. When you send the patient, 10% risk that we find a nodule. 50% of those nodules have not even been on the report of the radiologist because they focus on the cardiac vessels. And from the 50% which have been on the report, only 50% get a proper workup because the referring GP didn't realize that there is a nodule he has to take care of because his main interest was the cardiac situation. So we have to create awareness regarding that, and then we really have to come up with clear recommendation how and whom we want to send for which biopsy technology. And just finishing with that, is screening more important or is the incidental finding more important? These are the data from the National Jewish. Same period, 600 nodules, 600 patients went for a lung cancer screening program. At the same time, 8,500 patients getting a CAT scan for whatever indication. And the number on lung cancer patients they diagnosed on that subset have been even 5 times bigger than the lung cancer screening program. So lung cancer will come, and for lung cancer we have a lot of guidelines, but the daily problem we have at the moment are the incidental nodules, and we have to find solutions for that. And therefore, I believe that will be something which will be handled in centers of excellence. Those centers of excellence, they have to have very good technologies that we can diagnose it and maybe treat it in the near future.